And then we were like, you know what? Let's just ask our enrollees. Let's go talk to them. Maybe they'll tell us what we should do, or they'll tell us what they're most struggling with when it comes to some of these quality health indicators and outcomes that we're measuring. And that is what shifted what we did. We heard that they were financially struggling, and the quotes were so compelling. It was like any little bit of help would make a difference.
Welcome to The Other 80. I'm Claudia Williams. We all know that California is full of hardworking people. Nurses, teachers, delivery drivers, baristas who keep our communities running and are living paycheck to paycheck. This is the group Obamacare set out to help with Medicaid expansions and the state-based exchanges. And now, almost 2 million Californians get their health insurance from Covered California, the state-based exchange. But even with health insurance, they still struggle to pay rent and put food on the table and gas in the car. It's not often that these folks caught in the middle, who make too much to qualify for many benefits but don't make enough to afford the basics, actually get what they're asking for, extra cash in their pockets. Last year, Dr. Monica Soni made headlines with a new Covered California initiative to put dollars in the pockets of the working poor. So please welcome Dr. Monica Soni to The Other 80. It's so wonderful to welcome you, Monica, and I can't wait for this conversation.
Thank you so much for having me. It's really my pleasure to be here.
I want to just start with you. Could you please say your name and share with our listeners what's important to know about you?
Yes. So I'm Monica Soni. And what's important to know about me? Well, I will say I'm from Los Angeles. I rep it very, very hard. So the last couple of weeks have been really challenging with, some of what we've been seeing on the ground with the fires in Los Angeles. I'm also primary care doctor. So it's an identity that's really important to me and have spent most of my career working in the safety net or in public systems. And now I'm in this space at Covered California where just get to do a lot of fun and cool work at scale, but very heavily informed by the patients that I still see every week.
Most people who are listening know that Covered California is the state exchange option, but they may not have a sense of what role really you play as a coverage option in the state and how you're different from but interact with Medi-Cal. So I just thought it's good to situate us in that context for the work before we dig into some of the specifics.
We essentially are a startup within government service, right? When the Affordable Care Act passed, California was really on the edge, ready to launch and committed to this idea that if you weren't able to qualify for Medi-Cal based on income, if you didn't have insurance through your employer, if you didn't have Medicare, that we should actually serve you, that insurance is an important part of access, quality, and equity. So we started 13 years ago now, and just the numbers are incredible. We were at nearly 1.8 million people enrolled in Covered California last year. And this year, going into the next plan year, we hit 1.9 million people. And that's from the top of the state all the way down to the border. And frankly, it's mostly working poor. So over 60% of our population is at a federal poverty level of 250% or less. That's like a family of four, pretty much at like $60,000 or $70,000 per year. I mean, those are folks that are really living kind of right on the edge. And they tell us that, our population isn't healthy, young invincibles. That's not who we serve. While the average age is about 45, over 40% of folks have a chronic condition, number of folks accessing mental health services. And then when we ask them, a lot of folks with food insecurity, housing insecurity, or having been unhoused in the past. So it's a very interesting subset of the population. Like it's not quite any one thing. It's not commercial. It's not Medicaid. It's really its own subset of folks that are in transition and needing support. Over 88% actually get financial assistance through the exchange. And it's really incredible when you think about that. There are About 25% are paying $10 or less per month because of that level of financial assistance and where they fall from an income level. But the vast majority of folks are benefiting from those federal subsidies. And then, of course, we have a set of state subsidies to keep out of pocket costs as low as we can.
I love how you described it as a startup within government. I myself in the federal government have been part of various efforts that had that identity and that character. It also means that you have a ship. It's still a ship, but it's a smaller ship that you're turning compared to Medi-Cal. What kinds of options does that open up to you as an innovator that might be harder for a very large enterprise like Medi-Cal?
Our previous executive director, Peter Lee, really structured Covered California in a thoughtful way. And we do have flexibilities that other state departments don't. So we aren't part of HHS technically. We have our own independent board. Of course, Secretary Johnson, who's the current secretary of HHS, is our board chair, but it is its own board. And so either we respond to sort of what the board asks us to do or what our legislators ask us to do. So it's pretty different governance than other state departments. And then our budget is also distinct. So we're not under the governor's budget. We really are operating costs come from a percent of premium. So it's not even just taxpayers. Like we are beholden to who our enrollees are and what the premiums are in any given year. But I do think in our DNA is this idea of innovation. So in house, we have a research team that does randomized controlled trials. We're committed to hyper transparency. Almost all of our data is released. We stratify it by everything you can think of to really identify where there might be pockets of coverage that aren't there or outcomes that are suboptimal. And we do a lot of deep listening with consumers, with community to help inform what we do. So for 2024, one of the top, I think, downloaded or trafficked publications in health affairs was one of ours. So, and it was really about some email nudges. So, it was thinking about for folks that actually would be eligible in the public health online transitioning from Medi-Cal over to Covered California. We were trying to get as many folks as possible to effectuate. And so, it was this experiment of like, okay, if you call them, if you email them, if you do outbound in Spanish, like what will happen with those effectuation rates? And so, that was an example where we had like a true RCT and we trialed different interventions to see what was most effective. And then beautiful part, of course, is once we learn it, we embed that into our operations immediately. And so now that's just how we function.
We'll include a link in the show notes for that.
Yeah.
When you were on stage at Health, one of the things you were talking about is the investments you've made into population health. And I want to roll out this conversation in pieces. So the first piece is simply here you were in 2023, you had $50 million of fees that your existing health plans had paid to you because they didn't meet quality benchmarks. And you were trying to figure out how to use this money. And you approached it in a very different way than I think many payers would have. So talk a little bit first, before we get into the specifics, about how you approached how to use that money.
So the first thing was we didn't actually know how much money it was going to be actually until late into the process. So you can imagine how difficult it is to design something when you don't even really know what the budget is. We had an idea, but we did the scores from the health plans hadn't come in yet, and so we didn't have a locked in budget. So the first thing was, what are my legal parameters? What are the things that are
Good
going to get
place
me
to start.
sued or that I'm not going to be able to do? And frankly, again, to the earlier conversation, because really we're a startup, all of our council has a startup mentality. So they're like, well, I'm going to give you the parameters, but like I'm going to also tell you where the line is blurry or a little bit more flexible, which was very helpful. And I'm very grateful to them. They were close partners in this work. And then we did a little bit of a brainstorming session where we were like, should we build parks? What should we do that would like that nobody else is doing and or that maybe is so far upstream that it would really make a difference to folks? So that was pretty fun because then we had a list of, as you can imagine, dozens and dozens and dozens of things. But then we are like, okay, let's come up with some guiding principles. What are the things that would make us feel like we're making, smart decisions? Things like equity, thinking about not being redundant, that it's really additive, that there is some evidence base for, but it doesn't have to be perfect, right? We'll take that there's sort of like a seedling of an idea from something that was pretty rigorous that maybe we could try to scale because you're an academic. Not most things can't lift and shift. That's just not the reality of implementation and implementation science. So came up with some guiding principles, did really, really extensive literature reviews, didn't see a lot that, the exchange population is very specific. And then we were like, you know what? Let's just ask our enrollees. Let's go talk to them. Maybe they'll tell us what we should do, or they'll tell us what they're most struggling with when it comes to some of these quality health indicators and outcomes that we're measuring. Why isn't your diabetes controlled in a way that you want it to be controlled? What happened with your colorectal cancer screening or other preventive care that got in the way of that? And then we did the same listening, not just with our enrollees, but we did it with consumer advocates, with the health plans. We started to talk to the physicians, the practitioners, primary care docs who served our members, not general outreach, specific. We know that you're a practice that serves thousands of covered California enrollees. What's happening in your practice that might be getting in the way of this? So we cold called hundreds of covered California enrollees in multiple languages. I did some, I had interns do some, we had other people in my division do some because we had not done this type of work before. And it was so informative that we said, wow, okay, how do we get a little bit more of that voice? And so we sent out a sort of email based survey, again, in multiple languages, but still pretty free form. I think we had about 1,000 respondents to that too. So we had a lot of input directly from our enrollees. And that is what shifted what we did. We heard that they were financially struggling, and the quotes were so compelling. Any little bit of help would make a difference. Like, I can't pay my rent. I don't have gas money. I can't pay for groceries. I'm trying to hold on to this premium, all of these things. Like, so if you could even take any bit of that, it would be incredibly helpful to us. And then we asked some specific things like, okay, monthly, lump sum, which one? Food or transportation or childcare or this? And so we actually shaped the program based on what we heard from all of these stakeholders.
Was there any story that really stood out to you? I mean, I'm sure there were so many stories, but could you give us some examples of things you heard that were particularly compelling?
Yeah, I'll think the one that sticks with me a lot is some folks in rural communities who said, you know, if I want to eat healthy, I have to drive an hour to the grocery store that actually has produce. And now I'm deciding, do I spend my gas money on that
Mm.
hour-long drive, or do I eat what I know is less healthy for my family? Think stories like that where it was like these real trade-offs that we heard that people were making and sophisticated trade-offs that they were making. A lot of folks were like, "No, I've got childcare covered." Well, of course you've got childcare covered. If you have to work, childcare can't be the variable for you. So it was really like, okay, childcare is covered, but the food isn't covered. Like, I'm struggling to make sure that I can get food on the table every month and cutting it down to the wire. So that I think was very compelling to us, which was you've got folks that are managing their budgets in a very thoughtful way. They know what they should be doing and what they want to be doing and need to be doing, but there just isn't enough money to do it. And so that I think also shifted for us, which was, we trust our folks to make the right decision. How do we just give them a little bit of extra breathing room?
I love that. Not having a cushion also means that any small thing can throw you into a tailspin. So having a little bit more of a cushion is really helpful. There are food programs like SNAP available. I'm curious, what did you find in terms of people's eligibility and enrollment in that if they were eligible?
Yeah, so we asked them, we're like, "Are you part of a different program where you get some benefits?" And some folks were, but it increasingly felt clear that we a little bit had a subset of folks that were on this benefits cliff, where they just made too much money for Medi-Cal and therefore too much money for some of these other programs, and mostly weren't getting some of those benefits, unfortunately. Or you had folks who are mixed, in a mixed household, and so maybe one person was, but not everybody was. So it didn't seem like there was a significant safety net for most of these folks. That was not what they were communicating to us. It wasn't like, "Oh, I have the benefits, but they're not enough." It was like, "I don't have the benefits."
So you ended up picking three areas to focus on. Could you tell us a little bit about what those three areas were and what the structure of the benefit is that you're providing in each?
Yes, absolutely. And I'll just add one shout out to your point about how do you translate what you're hearing into policy. We stood up a Population Health Investment Advisory Council, so it had folks from CMMI and the other public purchasers and the health plans and consumer advocates, and we had a current covered California enrollee on the advisory council also. to be peers with everybody else and help us make these decisions. And so we would bring to them sort of this package of here's what we heard, here's what the literature says, here's kind of what we're thinking from a design perspective. What do you think? And then they would give us feedback. We would go into full public comment so people could write in or call in and let us know. And then we would iterate on the programs. And we did that for a number of things. And there were some where they were like, this isn't quite the right idea. I don't think you should really fund that at all. So once we knew that we had about 15 to $16 million, that shrunk, right? We can't do everything. So we decided we'll just do three things and based on the feedback from the advisory council and from others, we chose first what we're calling essentially grocery support, or our food population health investment. So again, when we were listening and talking to folks, food insecurity consistently was at the top of the list. It seemed like the one that folks were struggling the most with and hadn't figured out a way to close that gap. And some of the on the survey data, at least, the numbers were so high, higher than anything I had seen in Medicaid. For our Spanish speaking folks, particularly those that had chronic conditions, it was as high as 40% when you looked at the FPL of 250% or lower. That's just shocking. And that's why I said it felt like a benefits cliff. In the Medicaid space, those folks would have been, you'd be confident that they were eligible for SNAP or EBT or CalFresh. So we heard that. And then we started to go back to the literature and we said, okay, so food, is it medically tailored meals? Is it produce boxes? What is it going to be? And we just listened a little bit more to what the messaging we got from our folks was, which is they're making choices already. They just need that little bit of breathing room, and making super burdensome or restrictive programs maybe isn't the best way. And could we actually study this in a way that we don't have a lot of constraints, but we look at the outcomes in a more rigorous way? So we decided there weren't going to be any restrictions on that it has to be healthy or that it has to be, just from a farmer's market or anything like that. For the food program, if you're a single household, it's $80 a month for 12 months and it scales up. We're using the same scaling for household size that CalFresh uses. So it's not exactly linear, but more dollars for more people in the house. We focused on folks with a chronic condition because the literature was the most compelling there, that food insecurity plus having a chronic condition leads to some of those really challenging outcomes. And then we focused on 250% or less because that was what our data and our surveys had shown was the most kind of impacted population. So pretty simple eligibility criteria. Folks will screen in. So we're using the hunger vital signs, just the two questions in terms of food insecurity. So it's actually, the program has started this week.
Did it really?
Yeah. Yes, they're getting an inbound from us saying, "Hey, we think you're eligible for this program. Log in and let us know if you're interested. And if so, tell us the Hunger Vital Signs question." So just those two questions. And if they say yes, I'm really struggling to make ends meet from a food perspective. That's it. They just start to get the funds the next month by a reloadable debit card that they have. So that's the structure of the program. The cool part, though, is that we do have randomization in it, not placebo, but folks will either get a monthly distribution or they'll get a lump sum at the end of 12 months so that we actually can have rigorous evaluation. And so we've got some academic partners at UCSF who had sculpted survey questions for us along the way. And then we have full claims data so we can see if there's any difference in acute care utilization as well, at the end of this particular population health investment. So that's number one.
Yay. And congratulations on opening up.
Yeah.
I can't wait to hear what the enrollment is and what happens as you roll it out. So what are the other two?
Yeah, so the other one was, you said Paula. So Paula's my friend since forever. She's my friend since I was 17 years old. And so one of my closest friends, and we were driving somewhere and really talking about what would it mean to meaningfully use some of these dollars to change outcomes with a longer time horizon. And she was like, "Oh, have you heard of this CalKids program?" And I was like, "No." And she's like, "It's amazing. The state is saying every kid that's born after 2021 is eligible for a child savings account, which will help them be able to go to college." And the data is so clear, right? If you invest in a child savings account, even up to $800, the likelihood of going to a 2 or 4 year college is significantly higher. And then, of course, we know that that leads to financial upward mobility and better health outcomes. So I was like, "Oh, that's awesome." I was like, "How do we do that?" So I started to talk to the folks at Cal Kids and say, could we, for our kids who are 2 and under, put even more money in? So could we use the kind of infrastructure that you already have, but add some extra money and try to combat the real declines we're seeing in child's health the decreases in childhood vaccination, could we put a little bit of a different motivator in there? So that's number two. So every kid on Covered California who's 2 or under has the opportunity to have an extra $1,000 put into their CalKids account. And we're going to be kind of encouraging them along the way to go to their well child visits, to get their vaccines. Um, and so that one will go live next month. And it's a smaller set that we don't have as many kids because Medi-Cal is a very rich program in terms of financial eligibility for kids. But we expect that there'll be several thousand kids that will benefit from that. So that's number two.
Oh, that's great. And then primary care is
And then
also in
primary
there.
care. Yes. So we always try to think about what are the other things happening in the ecosystem that other public purchasers are doing? How do we amplify that great work? And one of the questions that always had existed was, who are our primary care providers as compared to those serving Medi-Cal, as compared to those serving CalPERS? So we did this network overlap map, and it was shocking. We found that over 70% of all of Medi-Cal's primary care providers are covered California primary care providers. It's the same docs. It's the same docs who are there serving, two huge state programs. And of course, they're serving some other lines of business too. And a meaningful chunk of them are these small independents in community of community who frankly are struggling. They're struggling to move to things like value-based payment. They're struggling to move away from fee for service to do population health. So DHCS had already decided they were going to commit funds through the equity and practice transformation work. And once we had that stat, we were like, we should really add on to that. These are critical providers serving our population too. So we have about 45 practices across the state who serve both Medi-Cal and Covered California enrollees. And there's funds that we've put forward into that program to help with that practice transformation, to help do that technical assistance on the groundwork that those practices need to make sure that the folks that they're serving are having those high quality, equitable outcomes, and to hopefully keep them in business for many, many years to come.
I want to double down on this question of how different public programs can create much bigger change by working together. Between the three programs of CalPERS, Medi-Cal, and Covered California, you cover an amazing 45% of the state. And so if you can work in an aligned way, maybe with different strategies, you probably have different legal requirements, different populations, but if you can be aligned about the goals and objectives and be thoughtful and strategic about how to work together, what an amazing impact that can make. And we also know for Medicare that where public programs work in a very clear directional way, private insurance tends to follow. So talk a little bit more about that effort to align the work across these three programs and what that might look like in the future.
Mhm. Yeah, it is incredible. I mean, 45% in California, and we're a gigantic state. So it really, to use the market power in this way is phenomenal. And so I think the very early work started around advanced primary care, building in the same exact contract language for our health plan partners across the three public purchasers. So things like primary care spend, transitioning along the continuum for alternative payment models from fee for service to more risk, all that's exactly the same and has actually now been in place for a couple years. And then we did the same thing with our financial accountability program. The measures that led to the pool of money that we're talking about here are the same measures embedded in CalPERS's program and the same measures embedded in DHCS Medi-Cal's program too. And so part of that is also to try to reduce administrative burden, right? Like, could we all say the same thing, care about the same thing as best as we can, to your point, be fully aligned so that the plans reduce their burden and then the delivery system, importantly, at the point of care has less burden from mixed messages from us as purchasers. The alignment now extends beyond the public purchasers. So we do a lot of work with the Office of Healthcare Affordability behind the scenes. We spend time, frankly, talking with our regulators at DMHC. Like, what does it look like for us all to be fully synced and have future visioning that at least is the same?
We think of health plans as payers, but really health plans are the mediators between the what I think of as the real payers, the employers, the public benefits program, Medi-Cal, and the members. How have they responded and reacted to some of these new initiatives? They probably assumed that 15 million might come back to the higher scoring plans, but also just what kind of engagement have you seen, both positive and negative, around some of these initiatives?
Yeah. So the origins of the Quality Transformation Initiative, which led to the pool of funds, frankly, that was co-created with the health plans too. I mean, I'm grateful for the level of partnership that we have with them, especially the clinical leaders. The clinical leaders are primary docs too, or cardiologists too. They don't want to work with institutions that have crummy quality measures. They don't want the proliferation of measures that aren't actually meaningful in terms of outcomes. So it was probably a 2+ year process to get the program in place, but it happened in deep partnership with the health plans and even the population health investments. There were a couple plans on the advisory council. We asked for deep engagement from them. Yeah, there's a little bit of resistance. I think the thought was that the money might go back to the plans. Most programs are sort of structured like that. But multiple of them have said to me since, you know what, where we landed was really good. I'm really excited to see what happens. I'm so glad about this. Or we know that our members are food insecure and we haven't been sure what to do about it since we don't have a funding stream to do that, right? It's not a benefit for us like it is medically tailored meals a benefit on the Medi-Cal side. So I don't feel pessimistic about all of the players in the ecosystem. I feel like the more that you get to know those folks, understand their motivators and can align, the better it is. And it's the same on the delivery system. Like this idea of villainizing anybody, I don't feel like that does us very good. And so you gotta bring people along. Some are faster than others, but mostly I think they support what we're doing and we are trying to support them in whatever ways we can to get to that same destination.
I'm going to talk about politics for a minute. The last time we had a Trump presidency, it was when there was a lot of calls still to repeal and replace. We're not seeing that on the agenda right now, but there are other policies and program changes that could have a big effect on both your people you cover and on your program. So, without asking you to have a prediction screen, which none of us do, I'm just curious what you're paying attention to and what kind of messaging you'd want to send out to your partners and members who might also be seeing the news.
Yeah, it's a fantastic question. The first thing we're paying close attention to are the federal subsidies that we talked about earlier. It is the thing that has made the care accessible or the coverage and then the care accessible to our members. It's why we had went from 1.8 million to 1.9 million in a single year, right? Record levels of enrollment because of that affordability. Those subsidies expire in December of 2025. That is how they were written. And if they are not extended in any way, shape, or form, we know that that introduces a lot of uncertainty, instability, and frankly, premium increases. So our estimates are that over 1 million people would have a premium increase of 60%. And that would lead to folks dropping out, right? We have a very price sensitive population. As we've talked about, every dollar is a dollar that they really need for something else. So we would start to eat back into those early years, 15, 20 years ago, the numbers that we saw of uninsured folks. And I think we know that that has a ripple effect across the healthcare system. So that we're watching pretty closely and trying to advocate where we can for extension of those subsidies. In a dream world, they would be made permanent, but at least extension of those subsidies. And then, of course, we follow very closely anything that might be Medicaid adjustments because we work very closely. And we've seen in other states like Texas and Florida where there wasn't Medicaid expansion, those folks went to the exchange, right? Those folks,
Hmm.
and so they've had huge numbers of folks on the exchange because they didn't expand Medicaid. So if there is more instability in the Medicaid space or changing expectations, I think we're also thinking about do those folks come to us? Do they float us? Do they still float us if there's no subsidies? So I think a lot of scenario planning. Overwhelmingly, folks, I think, believe the subsidies should be continued. I think you can say that and also believe that we need to address the underlying costs of care and that it shouldn't feel like a blank check. So I hold those two things to be truths and not intention. I think the question is, well, what comes first, right? Do you subsidize what is, well, I think we would all agree a system where there's a lot of bloat and we're paying a lot for maybe not the outcomes that we want. Do you let there be collateral damage? Do you say, well, until we figure that out, you gotta sort it out yourself, person on the ground who's working and trying to make ends meet? Or do we believe that part of the government role is to hold those people in a safer space until we can address some of these underlying cost drivers? And that maybe is just a philosophical debate.
Let's touch for a minute on data and technology. Before this role, I was leading one of the large health information sharing organizations in California. And we had many conversations with Alice, who was then in your role at Cover California, and other folks about how to incentivize and encourage data sharing and the integration of information across the ecosystem. At that time, we didn't really land on a particular strategy. There was the various state level strategies, but in my experience anyway, they hadn't really inspired a lot of new participation, at least by the time I had left. I'm curious where that stands right now and what you'd like to see happen.
I'm grateful. We've got some cool stuff happening across the state. I think in the interim, since Alice has transitioned to her role, we've got the data exchange framework. We have the qualified health information organizations, the QHIOs that have been stood up. I think the pieces and the pipes are starting to get put together. And I believe that the purchaser role is to be the heavy a little bit, right? Which
Hmm.
is show us that you're using it in a meaningful way, not just that you signed it and then that's it, but that you're, advancing care and care plans based off of this information. So that we do have contract requirements about that. We are in one contract cycle, and the new contract will start in 2026 to 2028. Our board will approve it hopefully next month, and we've got pretty significant language in there around our expectation that you're not just a signatory, but that you are meaningfully using it, and you can show us the ways that you're meaningfully using it. My dream, though, is that we go even further beyond that. And I know we're not quite at this stage, but what an amazing opportunity to reduce administrative burden if frankly the quality reporting was organized in this way, right? That you actually had the ability to look at, okay, for all Medi-Cal, for all covered California, for all CalPERS, like what's happening with breast cancer screening. And we know actually that you got that mammogram over there because we're using our data exchange in meaningful ways, de-identifying it, aggregating it, and rolling it up so we can all see, and then of course stratifying it by all the demographic factors. So that's my push, is not just that it's sort of individual person or human data flowing back and forth between two institutions, but that we've got more visibility across the state on these clinical measures, on quality, on equity too.
I love
So
I
that's a
love
little
that
bit maybe of a
vision.
pipe
Yeah.
dream. I mean, I'll never forget. This is years ago now, but I was seeing a patient in my primary care panel who had end stage renal disease and was on dialysis. And of course, I knew who that dialysis center was. They knew who I was. And he would come in and I'd be like, oh, okay, great. Do you have your last set of labs? Because they, of course, were seeing him 3 times a week and so had labs. So I didn't draw labs because they were drawing labs. Like, why would I do that to him? And he was like, can't you see that in this computer that you're staring at for our entire visit? He was so lovely. And I was like, no, I was like, I'm ashamed to tell you, I don't see anything from what happens at your center. And he was like, that's crazy. And so we had this elaborate system where I would write on a piece of paper all the extra labs that I would like them to please draw. He would carry it back to his appointment. They would do it, they would print it, I would wait for the next appointment, he would come back with this piece of
Oh
paper, and I'd be like, "Oh, great, your
no.
thyroid is normal." And it's just like it's bizarre, right? And we worked around it. But I think this is kind of the point. People expect and want us to be exchanging data in meaningful ways. We need to protect privacy in the right spaces, but folks know that that is a crazy system that is non-functioning for them. So I think we should push, right? Like thinking about our folks. If I know based on all these things I know about you that you might qualify for CalFresh, wouldn't you love if I could send that information over and the next thing that happens is just that you get a yes, like you've been enrolled? I think people want things like that and they want us in government to be functioning in less siloed, bureaucratic ways and making their lives easier in whatever ways we can. And data is a huge part of that.
I totally agree. And that example shows what a dedicated physician you are, but also, my gosh, it makes me want to cry. One of my recent interviews was with Cameron Matthews, who's the chief medical officer at City Block and also sits on a bunch of really interesting work, contributes to a lot of interesting work around the intersection of primary care and AI, and what are some of the most immediate and promising applications of AI, which could range from reducing the burden on physicians or patients to more clinically informed things. What are you thinking about in that space right now?
I'm an early adopter, so I'm excited about all of these things. Like anything that can make lives better, like let's see, and then let's put some parameters around it. So I'll talk about maybe some interesting conversations I've had in the last week with clinicians, and then I'll also talk about what we at Covered California are trying to do. So yeah, I was in clinic on Friday, and two different docs were like, "Oh, do you have the open evidence application, which is meant just for physicians? You have to log in with your NPI. I think it's a Mayo based platform, and it is what everyone thought doctors would use AI for. So you ask pretty focused questions and it like does a proper lit review and gives you like differential diagnoses and like, oh yes, this formulation of this drug is liquid and you can find it in that dose. So it's the things that might take us 10 clicks with the tools we have allows you to have a much more streamlined, faster interactions. We already know that our health plan partners are using Gen AI and other tools in a number of different ways. Some, just on the phone center or chat bots, and some for clinical decision making on closer to patient care side. And so we have put in this next contract cycle an expectation that they are telling us how they're using it and their use cases. We're not going to approve it. We're not the experts. We're not going to pretend we're the experts. But we do think that we have an important role as a steward and that eventually we might have a role in terms of oversight. So we got a lot of robust feedback on that particular contract language, but that's the ask. Let's share with each other, how are you using it? What seems to be working? And what guardrails have you put to mitigate against the bias that we know is in there, particularly in these really important moments of making decisions around patient care or utilization management? So I'm excited. I'm interested. I'm excited. I'm open.
In a conversation I had with Ziad Obermeyer, who does a lot of really informative work around bias in AI, and I said, like, what's the first piece of advice you'd give to any clinical entity? And he said, the first piece of advice I'd give is make a list of the algorithms you're using and define what they're doing. Like, just know what they're doing. You can go a step further and ask what data are they using to define what they're doing, because then you could see a disconnect. And he said you'd be shocked how many CEOs, how many leadership teams have no idea. So even if you go no further than asking them to tell you, you're actually accomplishing that goal of having them go to their teams and say, oh, by the way, what are we using right now? And the truth is they might be using third-party tools that embed algorithms that they don't know about. So I think that awareness of how are we using data, how are we using these tools, does the outcome we're looking for actually match up with the data? Because I think often where we found big disconnects and big bias, it's because the type of data we're using, like using claims data to define whether someone has an underlying undiagnosed clinical need. Well, definitionally, you can't do that, right? Because the claims data only show what services have already been used. So I love that you're doing that. Remind me the name. I remember somebody once years ago told me about, is it attachment 8? What's it called?
Oh.
And they were like, this is where the real magic happens. I was like, what are you even talking about? What is it? What is it called?
That is amazing. Yes. So we finally got rid of all the attachment 7. That
Oh,
used to be attachment 7, and we've streamlined it. So we have our regular kind of core body of the contract, and then we have attachments 1, 2, 3, and 4,
okay.
which have a lot of juicy stuff in them.
Okay. But people, and I went and I was very skeptical that this would be interesting. And then I started studying them and I was like, wow, this is really, really interesting. But then I found out that things will get previewed, but won't actually be in the contract. So then I had to be a little more careful to know what was actually in the contract.
Yes, but we are like hyper transparent. So all of the red lines get posted and then the final gets posted too. So if you give us maybe a couple more weeks, the final 26 to 2028 will be posted online. Yeah, we're very transparent. Everything's available for anybody.
Well, I can tell you we will not release this till after that is out. So I will be on the
Okay.
lookout for it. Just a final question. Anything more you'd want to share?
I will say only one thing, which is I've been thinking a lot about how do we continue to find all the joy in the work. I know many others are too, in clinical context and outside of clinical context. And even with evolving pieces at the federal level and state level, it feels like it can feel heavy, right? Figuring out how do you make modifications to the programs you have in place? What's the impact? Always doing this crystal ball type work. But it's moments like these, right? It's personal connection. It's sitting down, reflecting on what's happened already, why you're doing the work that you're doing, that brings me a lot of joy. And so I hope others can find that too, despite what is, real, hard, involved work that feels mission critical. Like it's okay to laugh and I don't know. We've decided to do dance breaks at work too, me and my director.
Wait, I
I'm just
definitely
like
want a
by
video of
yourself,
this.
dance break. It helps. So that's my last parting message. Do a
Oh,
dance break.
yes. I'm laughing because I friends invited us to go to a karaoke bar here in El Cerrito, and I was 100% not interested, but we wanted to go see the friends. And I danced my heart out for 2 hours, and I felt so much better afterwards. I did not do karaoke, however. That was one step too far. Well, thank you, Monica, so much for joining. I really appreciate you and your work. It was just wonderful to hear about it.
Thank you for having me.
Honestly, I'm blown away by Monica. She brings such brilliance, collaborative spirit, and innovative thinking. And these are qualities I've seen time and again in other civil servants I've been privileged to work with over the years. And now, many of them have been fired. Their organizations are under attack. Their purpose is being questioned. Their tools of contracts, regulations, data, and funding have been frozen, dismantled, or at risk of being shut down. And I'm not overstating things when I say it will take us decades to rebuild this capacity. We cannot afford to stand by and watch this destruction of human capital and critical infrastructure. We must fight to keep it as whole and strong as possible. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. Check out the show notes for more information on Monica Soni and her work at Cover California. There's more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.